السلام عليكم ورحمة الله. My name is محمد, pediatric cardiology consultant, and I am a professor of pediatric at Mansour University Children's Hospital. My topic today about a very common problem in outpatient visits for pediatrician, which is the pediatric chest pain. So in this presentation or in this lecture, we will talk about chest pain in pediatrics. We will cover the causes, epidemiology, and the diagnosis and the management of pediatric chest pain. Our topics will include introduction, epidemiology, causes, evaluation, approach and initial management, subspecialty consultation, disposition, and the messages from this lecture. Introduction. As all of you know that chest pain is a common presenting complaint in patients seen by pediatrician. And it's a very common reasons for referral also to cardiologist. And most common diagnosis, chest pain, most common diagnosis seen as outpatient visits by cardiologist after cardiac murmur. Why there is increasing concern nowadays about chest pain? There is fear in the community and increase in anxiety in the community regarding pediatric chest pain. Sudden chest pain in a previously healthy child is a very source of fear and concern for the family. This came from multiple issues. As we see now from the media around you, you can hear about sudden death in athletes, sudden death in a healthy person, extensive public education about the association between chest pain and ischemic heart disease or myocardial infarction. This make strong assumptions that the same can be applied for a pediatric patient. Actually, chest pain account for a very huge number of physician visits, up to 650,000 visits per year for patients between 10 to 21 year of age of all physician visits. Chest pain can exist as a chronic condition in pediatric population with persistent symptoms in about 45 up to 70% of cases. It's a common complaint also, especially in adolescent female. Adolescent female, when they are approaching the puberty, it's a very common complaint. What is the causes of chest pain in pediatric? Please remember this percentage. The non-cardiac causes of pediatric chest pain include or reach 99% of cases. So 99% of causes of pediatric chest pain is not cardiac. Idiopathic represent about 52%, musculoskeletal 36%, pulmonary causes 7%, gastrointestinal 3%, psychogenic 1%, and the actual cardiac causes of chest pain in pediatric age group 1%. The non-cardiac causes, which represent 99% of cases, musculoskeletal comes with 36%. A lot of causes from the musculoskeletal system of the musculoskeletal chest wall can induce pain, like costochondritis or pericardial catch syndrome or cervical ribs trauma, missed trauma, child abuse, osteomyelitis, like this. Idiopathic represent about 52% and psychiatric 1%. Pulmonary causes represent 7%. The reactive airway, patient or child with excessive cough usually complain of chest pain, sometimes pneumothorax, pneumomediastinum, pneumonia, chronic cough, pleural effusion, embolism, foreign body, CCAM, and also in rare cases neoplasm. The gastrointestinal causes of chest pain, esophagitis is the most common cause, and GERD and gastritis and peptic ulcer disease, also esophageal spasm, any esophageal problem like esophageal diverticulum, spasm, rupture, hiatus hernia, pancreatitis, subdiaphragmatic abscess, even diaphragmatic hernia also. Small diaphragmatic hernia, of course. The cardiac causes, which only 1% of cardiac of chest pain related to cardiac causes. Usually these patients are diagnosed. Yani it's really to have aortic stenosis to be diagnosed at the age of 6 or 7 years. This is congenital lesion usually present at birth, so the patient usually have a history of cardiac lesion. The most common cardiac lesion which is associated or can lead to pediatric chest pain: aortic stenosis, aortic aneurysm, aortic dissection, serious problem, coarctation of the aorta, coronary artery anomalies, mitral valve prolapse. Usually the most common cause of pediatric chest pain, especially in tall girls or patient, pulmonary valve stenosis, and also some kind of arrhythmia. طيب, acquired causes of our cardiac causes, acquired causes like cardiomyopathy, myocarditis, endocarditis, pericarditis, Kawasaki disease, pulmonary hypertension, Takayasu arthritis, cardiac tumors, whatever. Any acquired cardiac lesion can end with cardiac chest pain. Arrhythmia also. Usually, pediatric patients describe palpitation as a pain. Usually they cannot describe palpitation as a palpitation, but usually describe palpitation as there is something wrong in their chest, and sometimes they describe it as a pain. This could also related to extrasystole, premature atrial ectopics, premature ventricular ectopics, or any sort of tachyarrhythmia. If you encounter a patient or a pediatric patient as a general pediatrician, with chest pain, so you have to take very good history from the patient or from the parent, very good physical examination. You may elicit a cause of this chest pain, and sometimes you may need some diagnostic studies. The history. You should focus the history about the onset of the chest pain, the frequency of the pain, what is the precipitating factor of the chest pain, what is the relieving factor, any special characters for this pain, duration of the pain, location of the pain, if there is associated exercise intolerance or not, any palpitation or shortness of breath, any associated syncope or pre-syncope. This is very important to analyze the chest pain to figure out the cause of the chest pain. It's very important to know the difference between cardiac chest pain character and non-cardiac chest pain character. Cardiac chest pain usually characterized with, it's usually associated with exercise, or it's precipitated by exercise, associated with dizziness, syncope, pallor, associated with shortness of breath, usually relieved after a period of rest, short period of rest, and sometimes you may find something significant on examination of the patient, like a murmur. But non-cardiac chest pain, usually it's not related, of course, to the exercise. It can come at rest. Usually sharp, sudden, and short pain, not associated with dizziness, syncope, pallor, usually associated with cough, changes with inspiration and expiration, and usually worse with the movement of the muscles of the chest and arms, and sometimes if you palpate the chest wall, you may elicit or reproduce the pain. The cardiac chest pain pattern. The cardiac chest pain pattern can present it like anginal pain, which is substernal crushing pain. It has some radiation to the neck, to the arm, to the back, to the left arm, to the back. Sometimes it's tearing type pain radiating to the back. Usually this is with aortic dissection. Pleuritic pain, usually it comes with difficulty of breathing. Or exertional pain or exercise intolerance, usually with myocardial infarction and coronary anomalies and cardiomyopathy, or sharp retrosternal pain exacerbated by laying down or associated with fever, with especially with pericarditis. This is regarding the cardiac chest pain. The precipitating factor or the factor that induce or make the pain more worse. Deep breathing may exacerbate the chest pain of musculoskeletal origin or pleuritic origin. So if you move the chest wall, so this movement, it will move the muscles, movement of the pleura, movement of the ribs, movement of the joint, exacerbating the pain. So this deep breathing induces the pain. So this indicates that the origin of the pain is coming from the musculoskeletal system. The pain may worsen by swallowing. So clearly it's related to esophagus. Pain which occur with eating may be related to upper GIT, gastritis, H. pylori infection. Shocking or witnessed foreign body ingestion, maybe something making irritation in the larynx or the pharynx or the esophagus of the patient. Pain induced by exertion usually has cardiac origin or sometimes respiratory causes. Patient with asthma, usually sometimes they have chest pain with some exercise. Chest pain on lying down or sitting may suggest pericarditis. So you have to ask about the precipitating factor, so this may give you clue for the cause of the chest pain. Past medical history is very, very important to figure out the cause of chest pain. You have to ask about any congenital cardiac disease, any acquired heart disease, any previous attack of Kawasaki disease. Is this patient secular or not? This patient has any sort of collagen disease, rheumatoid, lupus, whatever, any treatment for malignancy. This patient has any mediastinal radiation before for any tumor. This patient has any renal problem, infection, chronic infection, or previous aortic disease, or syndrome like Marfan or Turner or Ehlers-Danlos syndrome with joint laxity. Usually this patient also have some chest pain due to abnormality of the musculoskeletal system. Family history is very important. Like hypertrophic cardiomyopathy, you have to ask about any early deaths in the family or death in the young age in the family, sudden death in the first degree relatively less than 40 or 50 years of age. Family history of syndrome like Marfan, Turner, Ehlers-Danlos, hyperlipidemia, any family history of premature atherosclerosis, or any hypercoagulability state. Physical examination, you have to give attention to the resting heart rate of the patient. Sometimes you can find sinus tachycardia may indicate pericarditis or congestive heart failure or even myocardial ischemia. Heart rate more than 180 in older child or more than 220 in younger may indicate supraventricular tachycardia or tachyarrhythmia, whatever the mechanism. Respiratory rate of the patient, resting respiratory rate also, if there is any tachypnea, may indicate some respiratory problem, pneumonia, pulmonary problem, pulmonary edema, arrhythmia, congestive heart failure. So this is very important also. Important vital signs to be observed. Temperature of the patient may indicate infection, pneumonia, pericarditis, pleurisy, or upper respiratory tract infection, or even severe throat infection, and it may cause some irritation in the esophagus, and tonsil tummy can may induce epigastric pain and referred as chest pain. Blood pressure, you have to give attention to the blood pressure. If there is hypertension, if there is hypotension, if there is narrow pulse pressure, may indicate cardiac tamponade. So the vital signs assessment in a patient, in a pediatric patient with cardiac pain, is very, very important, and it can give you clue to the cause of the chest pain. Physical examination, you have to see the general appearance of the patient. Maybe sometimes you diagnose the patient once he's coming into your room or onto your clinic with his phenotype, like Marfan or Noonan or Turner. You need signs of chronicity or chronic disease like weight loss or fatigue. Patient looks pale, cachectic, drooling, excessive drooling with foreign body impaction in the esophagus, tetany and carbopetal spasm with hyperventilation syndrome. So give alert to every signs to the patient and try to interpret it in the setting of this chest pain. After documenting that the patient is stable, after documenting a stable regular heart rate and rhythm, respiration, blood pressure, the clinician should focus on searching for the finding of non-cardiac cause. Please think for non-cardiac cause first. Don't link chest pain equal cardiac disease. No, as we said before, 99% of cases of causes are not related to the heart. So search for non-cardiac causes first before thinking of any cardiologist, before referring to the cardiologist, before stamping your patient is a cardiac patient. Please search for non-cardiac causes first. Exhaust yourself to exclude cardiac causes by searching for non-cardiac causes. So inspect for any bruising on the chest, any abrasion on the chest, or maybe missed trauma. You know, kids usually hyperactive, and sometimes they have missed trauma in the ground, on the furniture, or whatever. So try to find any signs of trauma or missed trauma. Palpation, any bony prominence or bony abnormality on a localized swelling in asymmetry in the chest wall may indicate some trauma. Reproducible pain, usually ask the patient to point to the site of the pain and try to palpate this area. You may reproduce the pain. This pain may be tender or you may find a problem in this area. Maybe you can find swelling, you can find subcutaneous hematoma. So you have to palpate the pain location. You have to palpate the pain location as indicated by the patient, and you can elicit or reproduce the pain at the costochondral junction or over the ribs. This also points to osteochondritis or osteomyelitis in this area. Do careful chest auscultation, chest examination, and cardiac also auscultation and cardiac examination. You may find any suggestive clue for the chest pain. There is a lot of diagnostic study, but you will not do all of this for chest pain. Usually you are guided by the clue. You are guided by the clue and guided by the information you collected from the history examination, and you may selectively ask one or very few diagnostic studies. Sometimes you don't need to do anything. Sometimes you need to do just very, very simple test to confirm your diagnosis. For example, if you have a chest trauma or something, you may do chest X-ray. Gastrointestinal, you may need to do something for the GI If you suspect a specific problem like severe gastritis due to H. pylori, you may go to H. pylori test. Pulmonary, may need to do chest X-ray, sometimes CT scan. So the diagnostic study usually guided by your suspicion of the etiology. So the approach and the initial management, usually it's determined by the clinical status on presentation, finding on history and physical examination. Usually a traumatic causes is not life-threatening. Reassurance is an important component of the treatment, and sometimes psychiatric etiology need a referral to a child psychiatrist. Approach and initial management. If the patient is unstable, which is actually rare in pediatric age group, however, patient with severe chest pain, has marked respiratory distress, severe hemodynamic instability, or even sudden collapse, so you have to go through pulse algorithm with special attention to the airway, foreign body, tension pneumothorax, severe status asthmaticus, if there is suspicion of pulmonary embolism, tachyarrhythmia, ischemic heart disease, and heart failure. So if the patient came with chest pain, unstable, marked respiratory distress, sudden collapse, so you will go through pulse algorithm. Right. If the patient comes stable, which is the majority of the patient usually came electively with chest pain, there is enough time for you to do all your evaluation, starting from history, physical examination, diagnostic test if needed. You can also, if you need specialty consultation, you can do all of this, and you have time to evaluate your patient in the proper way. The potential cardiac etiology, those with concerning feature of potential cardiac etiology on history or physical examination, number one, you have to do ECG. So if you encounter a patient with chest pain and you put a potential cardiac etiology in history or in physical examination, or you give a doubt, so just do basic ECG. And of course, the pediatrician should, general pediatrician should know how to read ECG as a basic ECG. A patient with finding of a serious cardiac etiology on physical examination on ECG should have consultation immediately with cardiologist. I mean, if you did a baseline ECG, 12-lead ECG, and you find something strange for you or something, you might see it as a serious problem, immediately refer this patient to the pediatric cardiologist, and he will manage the problem. Patient with normal examination and normal ECG but has a concerning history deserve follow-up with pediatric cardiologist. Send the patient with electively to the pediatric cardiologist within 1 or 2 weeks. There is no urgency to make the patient more worry or the family more and more worry. As long as your physical examination is normal and the BCG or basic ECG is normal. Sometimes you may need subspecialty consultation. If you have patient with a recurrent pneumothorax, or you may need pediatric surgeon. If patient has abnormality in his esophagus, in his stomach, and making chest pain all the time, so you may need pediatric gastroenterologist. The patient with chest syndrome due to frequent secular patient, you need a hematologist. Like this patient, recurrent pulmonary infection, tuberculosis, you may need to pediatric ID consultation. And so you may need subspecialty consultation according to the underlying problem you have. This is approach, simple approach to evaluation and the management of the patient with with chest pain, and this is summarize what we say in this lecture. So disposition and follow-up are determined based on the etiology of chest pain. If the patient, as we said, if the patient is unstable, this is emergency situation, emergency hospitalization, and in the PICU, pediatric cardiology, other subspecialty will be involved. We need pulse algorithm according to the situation of the patient, which represent actually the very minority of the patient. Even me, as a pediatric cardiologist, I never see a patient with chest pain came unstable actually. لكن most of patient or the majority of patient came stable patient with concerning finding abnormal finding suggesting life-threatening condition should have disposition determined in consultation with appropriate specialist. Stable patient with common finding up to 99% of children and adolescents with a traumatic chest pain have a benign cause, most frequently musculoskeletal chest pain, and can be discharged even immediately without any concern. I will give just two case scenario. Case one is a 14 years old girl. She is previously healthy and came to your office complaining of chest pain started 6 months ago. Pain is not constant and it occur when it occur, and it's localized to the precordial area, lasts for few seconds, sometimes related with exercise but without difficulty in breathing. There is no any associated symptoms. The past history and family history are unremarkable. The girl denies the use of drugs or cigarettes. Medical attention was sought due to chest pain and desire to join school basketball team. On physical examination, all vital signs within normal limit. Physical examination is normal except for some tenderness over the left third, fourth, and fifth costochondral junction. So very easy to say that this patient has a musculoskeletal origin of the chest pain. Case number 2 is 6 years old boy present in the emergency room with 1 day history of severe chest pain localized to the left side of chest. Pain improve in upright position, worse when the patient take a deep breath, and the mother states that the child was noted to have fever and decreased appetite 1 day duration. In addition, he was noted to have shortness of breath over the past few hours. Past medical history is significant for surgical repair of ASD to ASD secondum type 2 weeks ago, and the child was discharged 4 days after the surgery in a stable condition. He is not on medication. Physical examination: patient has respiratory distress, rapid breathing, rapid heart rates, but his oxygen saturation is normal blood pressure, peripheral pulse perfusion within normal, and heart sound normal with no murmur and fracture rub. So from this scenario, this patient has a recent cardiac surgery for surgical repair of ASD, and he has a fracture rub over the pericardium. He has signs of chest pain, and we can simply diagnose this patient has a pericarditis or even mild pericardial effusion. So this can indicate that the patient has a chest pain of cardiac origin. The home message: pediatric chest pain is a very common symptom in children and adolescents. The underlying cause is benign in 99% of cases. History and physical examination can determine the cause. The approach and the initial management is determined by the clinical status on presentation and the finding on history and physical examination. Chest pain and non-heart disease or finding suggesting cardiac disease need consultation with a pediatric cardiologist as soon as possible. So at the end, chest pain 99% of causes can be treated in your clinic as a general pediatrician. Only 1% can be referred only to the pediatric cardiologist. You may need some subspecialty consultation in certain selected chronic cases. And I hope this lecture was so beneficial for the clinical practice of all of you, and thank you so much. See you next time, inshallah.